Hi guys, welcome back to OffBrand with OnBrand.
Today we're joined by Dr. Setton, a reproductive endocrinologist at RMA of New York. He has dedicated his work to supporting the Sephardic community with compassionate, high-quality fertility care. Having walked his own fertility journey with his wife, he brings a unique level of empathy and understanding to every patient he meets. We're so excited to have you. Thank you for being here.
Very excited to be here. Thank you so much for having me.
Thank you. So, Dr. Setton, we'd love to start with you sharing a little bit about yourself and why you chose this field, maybe a personal story.
Yeah, sure. So I'm born and raised in Brooklyn. My wife is from Deal. I grew up, I'm actually Egyptian, not Syrian, okay, so forgive me.
Okay. Don't worry.
Okay.
You make the cut.
Yes. And so I went to medical school. I ended up finding my passion really sort of late high school, early college or so. Was very interested in interplay between religion and science, and that's sort of what drew me into medicine to begin with. And when I was in medical school, I had no intention of going into to becoming a fertility specialist. I thought I would become a cardiologist or maybe a developmental pediatrician were sort of the things I was kind of interested in.
Something that sounded more,
Yes, a little more like, a bit more routine, I guess, if you will. That, OBGYN world and this sort of, where I ended up was completely foreign to me. It was probably the last thing I would have put on my list going into medical school. Wow. My wife and I got married between first and second year of medical school, and after about a year, we started trying. After about a year without success, we ended up having an evaluation, and we found out that she had severe diminished ovarian reserve. She was only 26 at the time.
And you were still in med school. You didn't decide where you wanted to study at.
Correct. So I was at medical school at NYU. This is also before NYU tuition for medical school became free.
I
know, it's free?
Just missed
Yeah,
it. It
you
is
didn't know
free
that?
now.
Oh, I should be a doctor.
It is free.
Okay.
NYU medical school is free. Not while I was there,
But
though.
at least you were in New York and not in Philadelphia.
Yes.
Or
I was
For
very
your
lucky.
wife, that's so important.
Yes, I was very lucky. I spent basically all my life in either Brooklyn, a year in Israel, or basically the east side of Manhattan, because I was at NYU for
Unreal.
medical school and then ended up in residency and fellowship at Cornell, which is just on
Great.
the Upper East Side.
Amazing.
So I've been lucky that I've had good training just in New York.
Great.
Worked.
And so I was in NYU for medical school again, thinking that my path was going to go to either cardiology or maybe developmental pediatrics. I had done a lot of volunteer work as a kid with kind of things like that. It was just
I
sort
love
of
that.
what I thought I was going to end up doing. And then we, sort of stumbled into this world just by circumstance. So ended up finding out that, again, my wife had severe diminished ovarian reserve. Egg numbers were equivalent to someone in their 40s.
At 26.
At 26. We ended up going straight into IVF because we knew we wanted to have, a larger family. We were in low numbers already in our mid-20s, and so we didn't know what the future may hold. And so we did our first round of IVF. We had no fertilization. They said that there was egg quality issues in addition to having low egg numbers, which shouldn't be the situation in our mid-20s. Next one, we had no embryo development. We had fertilization, but no embryo development. Next one, we made it to transfer, but the transfer didn't work. We'd hit 3 cycles of IVF at that point, and we were recommended actually to consider donor egg. Went for another opinion. The answer was also donor egg. We decided that we weren't ready for that sort of step, and so we continued going. And we went for another, had failures again and again. But then on our 6th attempt, which we said was going to be our last attempt, we ended up having 2 embryos on day 3 of development, put both of them in. And a few weeks later, when I had the heartbeat for my one oldest son, it's because one of them had stuck. As soon as I heard that heartbeat on that morning, I'll never forget it. That was my big aha moment. And I was like, I had never felt a joy like that in my life. Wow. And I said, I have to bring this moment to other people.
Wow.
And so that was when I said, forget about it. I'm not going into medicine, cardiology, etc. That road. I'm going to OBGYN, and then through that to become a fertility specialist.
Wow. What was the doctor in you feeling when you were going through all of this hardship and times and trials and,
Yeah. So as someone who was in medical training at the time, we're trying, when you're at a phase in your development, in your career and whatnot, where you're just trying to understand everything. Just try to understand the science behind everything, understand why this is happening, what can I do to fix, and also it's sort of like typical male, archetype. Like you want to be the fixer. I can do it. I want to be the fixer. I want to, I need to get to the bottom of this. And so much so that when I was in my fellowship, so in order to become a fertility specialist, you do your 4 years of medical school, then you do 4 years of general OBGYN, so I was delivering babies and doing hysterectomies and all that sort of stuff. And then you do 3 years of subspecialty training in reproductive endocrinology and infertility. And part of that is about a year and a half of doing just research in the field, because they want sort of people to have a very comprehensive background. What I decided to do was to say, well, I want to find something that can be a treatment for something like what my wife and I had went through. And we did something very interesting. What we ended up doing was, because for a lot of people that are on sort of the path that we were on may end up needing donor egg. We didn't end up needing donor egg to build our family. Side note, we had our son, and then we did another 7 cycles of IVF after that.
You're being very casual about this.
Embryo, I know, I'm just talking about it as if it was, another 7 cycles of IVF. And again, just embryos going in, failing, etc. There was a miscarriage in the middle of all of that, so we did have one conception, but then ended up with my twins.
Wow.
It's actually kind of it was on the, and we found out the embryo transfer worked for this on our 7th attempt there. We hadn't gotten yet to the point of doing the ultrasound with our doctor. It happened to be my last day of residency, so I had my first, and then we tried again while I was in residency for our second. So we were on the way we were getting ready to go to our graduation party for chief residents. So all the chief residents, we were graduating. I said, let's go stop by labor and delivery floor, on the way, we'll stop in the triage room and I'll just do a quick ultrasound and we'll see what's going on.
Oh, because you had all the tech already. Why not?
Yeah. That's in my field, right?
Okay, you deserve a perk.
So we take my son Jack, we give him to one of the triage nurses, one of my friends out there. And I did the ultrasound for my wife, and we both saw it clear as day, 2 sacs.
2?
Oh my God.
2,
oh my God.
And our jaws dropped, and we were just pale as ghosts. We could not believe it after everything we had gone through. And we had put in multiple embryos in the past also. Never in a million years did we think that we would end up with twins. But I have twins that are 7 years old now.
God, can we just take a moment for your wife? I mean, you too.
Oh, she's the biggest.
But
no.
second wife.
Wow.
No, wife.
Yes.
100%.
She's my superhero.
She is the super. You
God.
gotta meet my wife. She is the best.
That is so much to go through.
Yeah.
1, 2, 3, 4 per child,
Per
even.
child.
7.
Oh my God.
And after all that, we had one naturally after that. So I have 4 boys now.
You have 4 boys.
4 boys.
Why does everybody on the podcast come with boys?
4 boys.
Because I'm also
How did it feel when you found out you were having one
4
naturally?
boys.
So when we found out, we were in shock, complete shock. I mean, to a point where I remember she woke me up. It was 5 a.m. She took the test. She was like, Rob. I was go back to sleep. This is not what are you doing?
Yeah.
And I remember, and as she walked across, I was in fellowship at the time. She walked across the street to my office, went and got blood work, and sure enough, that's what it was. She was that morning, we were laughing about it. I was like, this is not possible. We ended up naming him Isaac Yitzchak because Sarah laughed when she found out. She thought I'm too old. It's it's not possible for me to get pregnant.
Oh my God, I love that.
So we named him Yitzchak Isaac.
That's where religion
my
and
youngest.
science meet.
There you go.
Wow.
I love that.
I love that.
And all of this really gives you such a different perspective now that you're treating people going through these things. It's not, you're not just saying, go do this and go do that. You know how it feels to be told all these things.
Correct. I've been on the other side of the table, the other side of the phone calls. And so, I know no one wants to be coming to see me. And I remind my team about that all the time. Also, like, no one wants to be here.
Yeah.
So just take
you
that
know,
into consideration.
Take that into
yeah.
consideration when you're talking to them, when you're dealing with them, whether you're drawing their blood, whether you're whether you're talking about results or whatever it is. People come to me at a very, very vulnerable time, but that always has to be taken into consideration.
I love that.
yeah, I
And
love
sometimes
that.
it's like you just get so used to your routine and like,
Or you just feel like a lab
Yeah,
rat.
just
It's nice
becomes
for
lab
people
rat.
to like have that
Yes.
understanding, especially this process could be so clinical.
Yes,
Sure.
and we don't want people to feel like numbers, right? We treat people, not numbers. And so, my goal, even though I'm part of a practice that's big, I personalize everything that we do and always try to tailor things and try to the best of my ability to make people feel heard and that their concerns are addressed. And, it's not just lather, rinse, repeat, just do whatever the protocol is
Yeah.
and just go with the program and whatnot. I always take the time with my patients to go through everything as thoroughly as possible. So I was mentioning before that, I was in this like fix it mode, right? When we were going through these fertility struggles of like, why couldn't this happen? And I need to find a solution for it. So something that I did in my fellowship, as mentioned, we have this research time
Yes.
that we have to do. We did these experiments in mice where we basically did IVF on the mice, took out their eggs, removed the nucleus, like their DNA from the egg, and then took a cell from a tail, from like their tail, just like a
Okay.
skin cell, think about. And we put that DNA into the empty egg and then fertilized it and created an embryo. So what does this mean? It's like, how is this relevant to anything? For a lot of people who say are at a point where they need donor egg, either because they're out of eggs, because they've gotten older, or they're young with diminished ovarian reserve, premature ovarian failure, whatever it may be, and their only option to have a baby would be with donor egg. Well, not everybody loves that idea, and
'Cause
that
it's somebody
donor egg,
else's DNA.
It's DNA coming from another person. But say you could stimulate an egg donor, get their eggs, but remove that person's DNA. This is what we did with these
That's
mice.
insane.
And then we took the skin cell, right? So you can take a skin cell from the intended parent, right? From the woman who's with the infertility, take their DNA, put it into that empty egg, and then fertilize it with their husband's sperm. And now
It's
you
completely
can
their
create
child.
wow. So
You-
Is this
is
happening?
that happening? Or
So this is a whole new field of what's called in vitro gametogenesis, meaning trying to create eggs artificially, if you will, is sort of like the term that's used, but like that's used loosely. But this is one of, I mean, my field of medicine is incredible. It's constantly changing, it's constantly evolving, constantly moving forward, which is also another thing that makes it so interesting. And this is one of the potential things in the future,
Wow.
Wow.
where everybody can hopefully have a child that's genetically theirs.
You
Wow.
discovered
Yeah,
that?
is that
So
what
this is a
the-
technique that
Wow.
had been that we sort of, that had been started to be worked on a long time ago, but there was sort of like a moratorium that was made in the United States in terms of these types of experiments because there was concern about people modifying DNA and things like that and creating, and sort of playing around too much with things they shouldn't be doing in
Yeah.
terms of human embryo development and creating embryos and, what sort of
Yeah, they were
regulations
trying-
are
yeah,
there.
yeah,
And you
yeah.
can't just like make embryos for experimentation and whatnot. And so it was stopped. And again, we did this in mice, but we ended up creating a live mouse pup from this. This is something that's being tried overseas and things like that
Wow.
with human embryos now.
So we're hearing more about infertility. What are some common threads like contributing to like infertility, or has it always been there and just not spoken about? What do you
Or
what do you see?
why is it so prevalent?
Yeah.
So we're hearing about it a lot lately. And it's a combination of things, I think. So on the one hand, we have better diagnostic tools for it, right? So, a long time ago, people would just try to conceive and they would try 1 year, 2 years, 4 years, 5 years, 10 years, whatever it may be. Never really had evaluations and because there wasn't really...
Nothing was labeled.
There was
Yeah.
exactly. So there's more, there's a lot more knowledge about it now. There's more testing that we can do. The testing is not completely comprehensive. We still end up in a situation where about 20% of scenarios of infertility it's unexplained. We can't explain why it's going on, which is wild when you think about it. But we also, though, at the same time, have tools to overcome that. So our tools have all to help people with infertility become more prevalent or more widespread. And so there's, when we identify, and doctors, OBGYNs and whatnot are giving those diagnoses and they're referring, and because there's something to do about it, whereas in the past there wasn't really anything to do about it. Now, there's also some societal changes that have happened overall, and that's why society's talking more about it, right? People are delaying childbearing more in general, in the general population, and as we age, it becomes harder to conceive, and so it becomes more prevalent of an issue. So you hear about more people that are needing IUI, IVF, etc. But there are things that are happening globally as well. For example, on the male end of things, it's been recognized in the last couple of years that sperm parameters are declining globally. This data started coming out a few years ago out of the Middle East, believe it or not. Was sort of like the first place that was identifying these sorts of things. But it's a trend that's being seen globally. And while we can't really pinpoint exactly what is likely multifactorial, meaning there's probably several things going on. On the one hand, there's a lot of environmental exposures that we have now that we didn't have 50 years ago, right? So there's pollution, air quality, there's microplastics, there's things like that. All these sorts of things.
What about the e-cigarettes? I heard that's also something.
So any sort of inhaled, yes. So and smoking also, more prevalent.
Throw it out there, Doc. Everybody's listening.
Okay. So any sort of inhaled smoke can create what are called free radicals in the bloodstream that can directly impact the quality DNA of sperm or eggs. And so...
it's for both?
Yes.
Oh, wow.
It could be for both. So
Ladies.
I do not like smoking of any sort. And if a lot of people come to me and they say, oh, well, you Juuls, you hookah, this or whatever, I'm happy to be the bad guy and say we eliminate that completely. When you're trying to conceive... And these sorts of effects for men, the sperm is constantly regenerating, right? And so you stop it, 3 months later we see an improvement.
Okay.
Because the sperm cycle is about 2.5, 3 months, and so if there's any sort of lifestyle things that are compromising sperm quality,
that could be that temporary situation.
That can be a temporary situation. Cigarette smoking and things like that can cause damage to eggs, but the problem is that with eggs, there's only a limited supply, right? Every woman's born all the eggs they ever have, and they slowly get used up with time. So it's not like men where it's going to regenerate and whatnot. If you lose eggs, and that's it.
We always get the shorter end of the stick.
Always,
Wow.
yes.
Okay. So everybody heard it here.
What about in our community in terms of let's say our lifestyle and trying to get pregnant?
We spoke about
the
global
standards.
Why is it so common here?
It's a good question. So on the one, smoking could be a contributing factor. Hookah is very popular, e-cigarette, Juuls, etc. Those potentially can be impacting things. On the male end of things as well, saunas, jacuzzis, anything where the...
What about women end for sauna?
Women and that jury, that's fine, actually.
Okay.
Yes,
Sauna's
as far
good.
as we know.
We got one
Check
thing.
box.
Okay,
Yeah.
good.
Yeah.
Okay.
It's more important on the sperm end of things.
But it really does affect it. It's not just a rumor, because I feel like everybody always goes, it's just a myth.
Not just a rumor.
Okay.
And if you think about it, when testicles and ovaries come from the same origin, what's called a gonad, right? So that all starts at the same thing. And if you're, XX, it turns into an ovary. If you're XY, it turns into a testicle. The testicles descend down into the scrotum and are not within the abdomen like the ovaries. The ovaries are in the abdomen. The testicles are separate from the body. Why is that? Because the body is 98.6 degrees, and the testicles need to be cooler in order for the sperm.
Oh, so you're saying genetically men are different because they need this temperature difference.
Well, so the genetics and the composition of men and their anatomy that they present with is different than women, in that the testicles have to be outside the body. The reason that the testicles are outside the body is for a proper sperm development. The testicles have to be cooler than what the body is, and so if you're in a situation where the testicles are excessively warm, such as a long time in a
So
sauna,
sauna,
or
steam, jacuzzi, all the
etc. All those situations can compromise, and it's not like an absolute, right? I mean, sperm are very hard. It's not that you go into a sauna and all of a sudden you have 0 sperm for that month or anything like that. But it can compromise your
Saying it's a
numbers
lifestyle.
and the movement of the sperm.
In addition to maybe cutting out smoking that month, just be conscious of all the things that are adding into it.
Correct.
Okay.
Binge drinking also can compromise sperm egg quality in a
Really
temporary
now?
situation. We don't like binge drinking when trying to conceive.
What's binge
as well.
drinking?
What's binge
like
drinking? 3
social
martinis.
drinking. We're talking about
social drinking
parties,
is
How many
Saturday
martinis?
night.
Like 3 is considered?
Yeah, how many martinis?
So for men, we say up to 7 drinks in a week is acceptable. For women, up to 4 in the trying to conceive
You know
time.
what? I just give up. Okay. Can't have anything. Okay, so alcohol. We're limiting alcohol.
We limit
What are
alcohol.
some other
These are
things?
things that we recommend. Exercise we love. Okay. With the exception around ovulation time, I don't love HIIT type of workouts because
Cardio.
It's like really the more intense things, the things that are sort of designed to make you go from 0 to 60.
Jumping cardio.
Yeah,
Dance cardio.
I have to go to one of those classes to know what they're like. I don't know. But the idea is this.
If your face is purple when you leave, is that considered?
Yeah, if, you don't want your heart rate going to over 160. The things that are sort of these workouts that are designed to increase your cortisol levels, the body is like, well, what's going on? There's I'm in too high stress of an environment, and it can impact your ovulation quality. So just really, I would say if it's something that makes you happy, go for it, but just avoid it in the plus or minus 2 days or so from around ovulation to avoid that. But otherwise, please go ahead and exercise.
Okay.
Interesting.
Love that.
That's the only caveat to it. Again, I encourage exercise as much as possible.
Just in terms of ovulation.
Just around ovulation, not super high intensity.
Depending on your goals.
Correct.
What about
correct.
food and eating and water and...
Yes, so hydration super important. Okay, yes, we want healthy, clean foods, and in general, the ideal scenario is avoiding cooking in things that can, with Teflon and using plastics and things like that. Sort of clean environment is the ideal. There's no one really knows a specific type of diet that's best for fertility, but the running theory out there in the medical world is actually a Mediterranean style diet is best for conception. So very likely what we're having. Things with chickpeas and the different types of beans that we have in our food. Like Mediterranean style is basically a Syrian diet.
Great.
Okay.
Yeah.
Love that.
Wow.
Yes.
Great.
So check box.
Though we check that off. We're doing well in that department. Something that I want to mention that's related to, so I mentioned that when we're in a situation, say, of high cortisol, high stress, etc., the body doesn't really like that around ovulation. That also comes into different lifestyle things where people exercise too much. So there is something as exercising too much as well, with having either or restricting what you're eating as well. We want health. We want balance, essentially, is what we want. We don't like things that are too much. We don't like things that are too little. We don't like to be on either extremes. In medicine, we like everything to be average. If your BMI, your body mass index, is too low, there could be problems. If your body mass index is too high, it can be problematic as well. The body can sense, and if we're in a situation, say, where we are, say, underweight, not nutrition, not getting good nutrition, exercising too much, the body senses that we're in a time of stress, that maybe there's not enough food around. Maybe this is not a good time to bring a baby into the world.
Wow.
And so when the body senses that degree of stress on the system, the first organ system to shut down is the reproductive system.
Wow.
That's what happens when the body feels stress. It's the first one to go.
So that's when you lose your period.
That's when people will stop getting regular periods, or they'll get very light periods, and I'm not sure, and whatever it is, or periods will go away completely because their body says, shut down the system, don't ovulate.
Wow.
Because it's not a good time to be bringing a baby into the world. We're not in a safe environment. And so that it's a very important thing because I think, in the community, there's a lot of stresses and there's a lot of pressures and whatnot, and image is important, and there's a lot of there's a lot of stresses that people have around this sort of thing, but it can reach a point where it becomes unhealthy. And it can be at a point where it prevents you from being able to get pregnant.
Have you seen that in cases you've worked on where it's come into play?
Absolutely. So there are situations, so this is a category of, so one of the major categories of infertility is called ovulatory dysfunction. So there's sort of a couple of broad categories of infertility. There's an issue, right? You need three things to have a baby, right? There's birds and the bees, but the doctor version, right? You need sperm, you need egg, and you need a uterus with open tubes. So those are sort of the three basic components. With the egg, we care about the quality of eggs, which is dictated by your age, the quantity of eggs, the number of eggs that you have, and the ovulation function. Are you releasing the egg in a healthy way? In a situation where the body is in is what's called a hypothalamic state, meaning that the weight is so low or the exercise level is so low that there's sort of this extreme environment going on, the signals that go from the brain to the ovary to tell it to ovulate shut down. It says stop sending those signals. It's not going to function anymore because we can't bring this forward. We have to have a critical body mass, a critical sort of weight, etc., for any individual in order for that to resume. And depending on the length of time that this sort of insult to the system has been going on, whether it's eating disorder or whether it's the excessive exercise, etc., the stress on the system, it sometimes can take years for that to bounce back.
Wow.
I've seen it take years. Because it depends really on the amount of time that this has been going on.
And also how long it takes you to recover that connection.
Correct.
To, nutritionally stabilize.
Correct. And so I often have to work in conjunction with nutritionists and specialists and whatnot to make sure, and psychiatrists as well, just to make sure that people are in a good state in terms of their relationship with food, with their body, etc., because it really ends up being very critical, not just because, when the body's telling you that it's not ready to ovulate, that's obviously a big sign. Now, I can overcome that, right? I can give you the hormones that you need to, to release an egg, and I can join the sperm and egg together.
Yeah, if you just do IVF, is that the fix?
We overcome it. We can overcome it. But I always want to make sure that you're in a good state ahead of time, because once I can put the embryo and we can get you pregnant, I can support the early pregnancy. But then you have 9 months, it's on you.
Yeah.
It depends on what you're taking in and what you're doing with yourself. And you want to make sure that you are able to nourish this precious cargo and be able to have good fetal development, good fetal growth, because everything that happens in utero can have impacts on children later in life. And so it's really important, before, we jump into treatment to help solve the issue, we also have to treat the underlying cause and really just make sure that we feel like that people are well supported and that be able to have a healthy term pregnancy and a healthy baby, healthy mom, healthy baby.
Yeah.
That's what we want at the end of the day.
I love that you're saying that. It's so full circle. You don't just do the fertility. It's you work with the nutritionist, psychiatrist, everything.
Yes. And we're very lucky in our community that we have a lot of support for those sorts of things. And outside of the community, of course, but if you just stay in the community and sort of be with people that really understand where you're coming from, that's all available, which is incredible. And people are talking about this more and more. And that's what I think it's really important. I'm really happy that I'm here with you guys, because I want to, give,
us too.
I really want this message to go out to people.
For sure. Would you say that working in RMA, there's so many different doctors? Would you say that because maybe you work with majority of our community, is this something you see more than your co-doctors, co-workers, or this is a general thing?
So it is, we live in New York City, and so this is definitely not something that's isolated just to our community. It's something that we see across the board. Is there, I would say, a higher trend maybe in my practice than others? It does feel like that, but maybe my opinion might be a little skewed because I'm seeing what I'm seeing.
Gotcha. Okay.
Yeah.
Could you walk us through some of the more common things, PCOS, endometriosis, any of those chronic health issues that do also impact fertility?
Absolutely. So PCOS and endometriosis are common things. Both of them have prevalence of about 8 to 10% of the general population. And PCOS is probably the most common ovulatory disorder that we end up seeing. What happens with PCOS is that someone is born basically with a higher than average number of eggs, which sounds like
Yeah, it sounds like a good problem
Sounds
to
good.
have.
right.
Yeah.
Okay, great. I have so many eggs.
I mean, I guess you said you want balance,
Right,
so too
right.
much, not good either.
And right, exactly. In medicine, we like everything in the middle. Too much of something can be a problem. Too little of something could be a problem. When we have too many eggs, basically what happens is that in order for a good, healthy ovulation to happen, the hormones between the hormones of the brain and the hormones of the ovary have to be in good communication with each other. When there's a lot of the eggs that are there are releasing hormone. If there's too many hormones, if there's too many eggs, then that's too high estrogen, etc. That's happening. That throws off the balance between the brain and the ovary. There's also other things that happen with PCOS sort of in the background, but that's sort of like the theory behind the basic underlying issue that we have there. And now what we often have to do, and so PCOS also classically is thought of as someone who's very overweight, has a lot of hair and things like that. PCOS really is a very wide spectrum. And there is obese PCOS and there's lean PCOS. And both of those categories can have issues with ovulation function. It's usually actually a pretty quick fix. This is where we can do low-tech things like Clomid or Letrozole, just like pills that you can take that just sort of help push the hormone system along to get a good ovulation to come about. And this sort of situation is probably the best prognosis in terms of reproductive outcomes. PCOS is also important just to be aware for people with PCOS. It can be very difficult for them to control their weight. It could be, they could also have high male hormones in the system because of these hormone imbalances. And so there's a predisposition for acne, for issues with like hair loss or hair growth on parts of the body. They don't want hair growth.
So if they have any of these things, that's an indication. Maybe check it out if you don't know if you're diagnosed with it or not.
So if you have the major clue to PCOS is if you have irregular cycles. What do I mean by an irregular cycle? More than 35 days apart, from the start of one to the start of the next. Two more things to mention about PCOS. With PCOS, it can also impact your body's metabolism, and there's a predisposition for prediabetes and diabetes, no matter what your weight is. And so sometimes people have to be treated for that. In addition, long-term, there's also a predisposition for depression and anxiety with people with PCOS because of the hormone imbalances that are there is what was presumed to be sort of the culprit behind that. But also because there's higher chances of having issues with weight control and whatnot that can predispose to that as well.
I feel like it's all over my Instagram.
PCOS
and what to eat and all these things. Is it that common?
It is up to 10% of the population with PCOS. Wow. Very common.
So it's like 1 in 10 people. If you're sitting in a room with your friends, 1 in 10 of you have to have it. It's crazy.
Right, interesting. Yeah. Like, is there anything specific to do for it?
So the best thing to do, if you have irregular cycles, the best thing to do, honestly, is to be on birth control pills. Oh. One of the issues that can happen with what's called unopposed estrogen, meaning if, say, you have PCOS, that's confirmed, diagnosed by your doctor, by a general OBGYN, and your cycles are very irregular. You get a period once every 3 months, once every 6 months, once every year, whatever it is. You just don't get a period because you have PCOS. We don't like that to happen because your uterine lining is exposed only to estrogen without progesterone. And what does that mean? It can predispose actually to like precancerous lesions and things like that. So it's important
so it's
to
definitely
protect
something
the
to
uterus.
look into is what you're saying.
100% something
on top
to look
of it.
at whether or not you're trying to conceive. And so the way to best protect the uterine lining, if you're in a state of, point in your life where you're not ready to conceive, birth control pills is really first line. And if you have a contraindication or can't tolerate birth control pills, there's other options out there as well.
Got you.
Endometriosis is a bit of a challenging diagnosis to make. Endometriosis essentially is a chronic inflammatory condition where the tissue that should be just confined to within the uterus ends up traveling elsewhere in the pelvis. And it's inflammatory. It can cause issues a couple of different ways. It can compromise the quality of eggs. It can also cause issues with the function of your fallopian tubes. It could also impact the implantation process because it causes it also causes sort of like disturbances in hormones and resistance to hormones and things like that. Not everybody with endometriosis has infertility, but there is a high association with it. And endometriosis is very difficult to diagnose because not everyone with endometriosis will have any symptoms. But the common symptoms are severe pain with periods and pain with intercourse. Sometimes you can have abnormal uterine bleeding patterns as well. But those are sort of the classic signs, symptoms of it. It sometimes can be found on imaging, but usually not. The way to definitively diagnose endometriosis is actually with surgery. And so, usually we say, well, if we're having pain, etc., treat the pain. If there is signs of endometriosis and it needs to be managed surgically, it has to be managed surgically, but there are medical options that there are for it before you have to do surgery. And if you're in the category of people where endometriosis is causing infertility, then treatments overcome that also.
Okay, so 2 things to what you're saying. Take these things very seriously, even if you're not at a point in your life where you're thinking about having kids right now. If you have either of those things, it's something to just be mindful about, making sure you take care of. And the other thing is that there are treatments, so you don't have to be so stressed if you do have them that you won't have fertility. There are things to do.
Correct.
So, talking about all these different things, what about egg freezing? You're saying a lot about eggs, how they're great until like a certain age.
Yeah.
Can you expand more about that?
Yes. So there is really a window of time where conception is easier and the window closes, right? Everybody runs out of eggs at some point. Everybody goes through menopause. The idea is that so on the one hand, so there's egg quality and egg quantity, as we mentioned before. Quality of eggs is driven by your age. And when you're in your mid-20s, that's sort of peak reproductive potential, 75% of the eggs are healthy. Wow. When you're like 34, 35, it's like 65%. So not that much of a difference into the early 30s. But from 35 years old, when 65% of the eggs are healthy, to the time you're 40, it drops off to about a third of the eggs being healthy. By the time you're 44, it's like a single-digit % of eggs that are healthy. So there's this,
and that's if your fertility is normal.
That's even with correct. And
so you don't even know what you got going on.
This is just average national, or average global data on what we know from, from millions and millions of data points that we have about this sort of thing. That it's not something magic that just happens when you wake up on your 35th birthday, all of a sudden the quality of egg starts to plummet. But there's a lot more rapid of a decline. It's really steep once you're in the later half of the 30s and into the early 40s. Everybody's sort of inflection point for that is a little bit different. And so one of the things that we think about, one with people who either are single or aren't in a situation where they're ready to be having children, or if they're, married later and they want to have more kids but down the road or for whatever it may be. That's where the concept of fertility preservation comes in, trying to preserve your fertility for the future. So this is where freezing comes in, either eggs or embryos. So you got married a little bit later, but I really want my 4 kids or my 5th, depends on what tuition's like at that time or whatever it is, right? But you want to be, what some people do is try to prepare for that by undergoing the IVF process and freezing embryos, or single and just haven't found the right person, but you want to be setting yourself up in the future. You want a family.
When do you think you should start thinking about that? At what age?
So in my mind, so everybody has different opinions on this. My opinion on this is that I think that the best time is between the ages of 30 to 35 or 30 to 34 or so, meaning the early 30s, because you're at a point in time where, again, your quality of eggs is not that different than what it was in your 20s. And you're also not in your, it's not that it's too late to do it in the later 30s, but because of the issues that you have with quality of eggs, you just need a lot more eggs that you need to freeze in order to set yourself up for success in the future. And you'll have lower numbers at that time also. So you have lower numbers, lower quality, later half of the 30s. And so you want to ideally try to get ahead of it. And so I think the 30 to 35 time is sort of the sweet spot. You also... you don't want to be doing this when you're 22 or something like that, right? Because the likelihood that you're going to need to use it is a lot lower in that sort of situation. So, you give it a little bit of time. The ideal scenario is you don't use these, is that you use your frozen eggs or embryos as a backup, essentially. Yeah. When the time comes, you try. If it doesn't work, you lean on those. But you at least have them sort of as like an insurance policy.
But let's say, somebody's 30, 31, they're, a girl, she's still looking to get married. It's not happening yet. What's the line between like I'm being dramatic, I need to freeze my eggs, versus this is a smart thing to do? And also it's costly.
Yes. I think if you're over the age of 30 and you're single, you are not being dramatic. I think it's completely appropriate. to be doing, especially if you want a big family, especially if you want more than 1-2 kids. I think it's and look, and again, it's not that you're going to ever, you may not even ever end up using them, and that's totally fine. But if you're in a situation where you really wanted to be used, where you really did need them and you didn't have them,
You can't go back.
you can't go back in time. You
Yeah.
can't go back in time. And so in my mind, and I know that this is something, and I'm happy that we're talking about this also, because I think it is something that's important. Because there are plenty of people in the community that are married in their early 30s and they're pursuing careers, and there's things going on or whatever it may be, and maybe it's just a matter of time. But if they have these that and there's plenty, and this is not something that I'm talking about that's never been done in the community. This is something that
You would see this
this is something that is happening, and people should know that it's happening.
Good.
Yeah.
And they should be okay with it happening.
And
Because
take away
it
the
keeps
shame
you.
about it.
There should be no shame in it. I've spoken to community rabbis that have been in support of this as well. I won't name any names, right?
course.
Because whatever. But in my mind, I think it's an important conversation to have.
Great.
Okay.
Love
I
that.
mean, I love that we're talking about this, and if anybody's thinking about it, well, you heard it from somebody who's a specialist. So take your fertility seriously.
Let's say you freeze your eggs or anything, or in general, the whole IVF process. How does it work? And if someone is going through it, how could you support them?
That's a loaded question.
Okay, just break it down.
It's a great question. So the way that it works is that we have to. So for egg freezing is similar to IVF in that you have to do about 2 weeks of daily hormone injections,
Okay.
and then there's a procedure under anesthesia where we extract the eggs, and then what happens with the eggs is they get then just frozen in time. And if you're doing it when you're 32, they will stay 32-year-old eggs, even if you're coming back to use them in 10, 15 years after that. There's no freezer burn that happens on them. or
Technology's
anything like that.
crazy.
It's wild. 65 to 70% of 32-year-old eggs are going to be of good quality. But then if you're 40 and you're ready to have a kid at that
Yeah.
time, when it's a third of your eggs, again, if you can't get pregnant on your own, you're better off using these frozen eggs from a younger age at that point. And again, this is not for everybody, but in situations where where
It's good to have the options on the table.
Yeah.
It keeps the door open for different options for the future. And if you don't use it, you don't use them.
Yeah.
And that's it. So say you're coming back to use your eggs. What we do is we unfreeze the eggs. So you already did the hard work in terms of the shots, the anesthesia, etc. All that happens in the future is we unfreeze the eggs. We join them with sperm in the lab, create an embryo, and grow that in the lab over about a week, and then we have that embryo is what goes back into the body. When it goes back into the body, it goes into the uterus. It's just like a fancy Pap smear. It's no
So you don't have to
anesthesia or
take
anything like that.
hormones.
So there's some situations where we do have to give hormones. It depends on, we usually
What's going
do
on
just
there?
to help create what the window of implantation.
Okay.
It's usually estrogen pills and a once a day injection that you have to do at that point.
Once a day for how long? A week?
It's too
For like
much stuff.
6 weeks.
Oh, 6 weeks.
It's a
wow.
long time.
Wow.
That's what's called a medicated cycle. There's like natural embryo transfers that are done as well, where we rely. And again, this depends on if you have good healthy ovulations. We can wait until the body naturally grows its own egg for that month. We can trigger it to release, so it happens in a very timely way. Because then we have to be able to put the embryo in at the exact right time.
Got
It's
it.
a very narrow, what's called a window of implantation, which is only a couple of hour window of time
Wow.
that an embryo is able to stick in a uterus, and so we have to get it there at the right time.
Wow.
It's just crazy because if you have a kid by accident, there are so many things that go on to these accidentals. Like you have to be playing get a lottery card. What's this accident? It comes down to a timely
Hashem.
hour.
It's
Hashem.
Hashem.
The more you think about it, there's like a million miracles that have to happen for there to be a baby.
Wow.
It's
That's
wild.
crazy.
It's
Crazy.
wild.
I don't know. I
It's
just
wild.
thought like when we grew up, it was like, oh, you blink, you're like, okay, I don't know, I can
Yeah.
get pregnant.
Yeah.
It's now it's like if you wanted to, it's a science
It's
experiment.
Yeah. And even
God.
even people who are fertile, like 100%, everything's fine. The sperm is perfect, everything is perfect. And you're in your mid-20s, peak reproductive potential. Chance of getting pregnant each month is about 20%. That's
Wow.
sort of like peak of
That's
what
not a
what
lot.
natural fertility
I'm
ever
not
is.
good with numbers, but
People
could
are
you
always
tell me?
very surprised when I say that.
That's very
Yes.
little percent.
Yeah.
And I feel like everyone's like, oh,
for sure.
When
we have
I'm ready,
kids.
I'll
Yeah.
try and it'll just happen.
It's just this expectation.
It could happen first month, right? 20% of people will.
Get a lottery
but
ticket.
for-
Yeah. Yeah.
Mega Millions is very high right now.
Nah, I swear.
But it's nice that there's like, I guess, these conversations, and especially a doctor like you who's been through it could help people that like you feel this pressure, everyone's doing it, I have to get pregnant, or it's so easy for all my friends. So just talking about these things
For sure.
is important.
Would you say there's like signs, symptoms, like any advice to anybody who's listening, either that could be getting married or is married, or anything that, you know, to start to think about how fertility comes to the picture? I just feel like, how could we not avoid infertility, but
Right.
how could we avoid infertility?
How can we
The best
be
we can,
prepared?
or like be
Yeah.
prepared.
Like
Yeah.
game plan, I guess.
Yeah, game plan.
Yeah. So I wish there was a test that we can do that can tell us who's going to be fertile and who's not going to be fertile. We know that overall, 1 in 8, some people are saying now 1 in 6 couples are going to end up having infertility, which is
That's a lot.
But at some point, it could be after they already have kids. Like,
it could be secondary
Yeah.
infertility.
Yeah.
Yes.
We just had Jacqueline on the podcast.
Yeah.
She had 4 kids, and then all of a sudden a problem. It's
Yeah.
It's just insane.
Yeah. And so we never know. You never know up front
What's gonna be.
what's going to be. And so you have to just try, essentially. If you're under the age of 35, you try for a year. That's if you have regular cycles. If you have long cycles, like we were talking about before, more than 35 days apart, for example, that's a sign that there's something wrong. You should get evaluated before.
By who?
It's fine to start with a general OB/GYN.
Okay.
But they may escalate you to a fertility specialist. If you are someone who has a known diagnosis of endometriosis from beforehand that was diagnosed when you were younger, can you try on your own? You certainly can. Do you need to be trying for a year? You don't. I would say 6 months is a reasonable amount of time before escalating and
Taking that next step.
And taking
Yeah.
the next step. Because because most couples will conceive within the first 6 months of trying. For some couples, they just need a little bit more time, and that's totally fine. And that's why we tolerate up to a year. But if you have some known barrier, it makes sense to be evaluated.
Do you have to wait a
sooner.
year? Because that sounds like a very long time.
If you have real signs that there's something going on, meaning like irregularities in the cycles, if you have severe pain with periods, severe pain with intercourse, if there's another known risk factor, like you had cancer in the past and had chemotherapy, if you're either male or female, that can compromise your eggs and egg numbers and sperm numbers. If there's any sort of known thing, get evaluated sooner. If you're young, you should give it time. Again, as long as you're ovulating regularly, you should give it time, because once, what we don't want to do also is overtreat as well.
Yeah.
Because that comes with risks as well.
What about genetic testing? Do you recommend that?
I highly, highly recommend genetic testing for couples. We historically think about it as being something that's in the Ashkenazi community, Hasidic communities, etc., where there's Tay-Sachs, cystic fibrosis, different things that are more prevalent in those populations. And it's absolutely true. And what those communities have actually done, particularly in the Orthodox communities, is they do, there's Dor Yesharim or J-Screen. They have basically what they'll do and I see a lot of these patients as well. And the idea is that everyone's born with 2 sets of DNA, right? One from mom, one from dad. You might be a carrier for a bad gene, right? You got a bad gene from one parent, but a good gene, a healthy gene from the other parent. But because you have the healthy one, you have no idea you carry a bad one beneath the surface, because you're fully functional, you have the good, healthy gene. But if you and your husband both carry the same bad gene, there's a 1 in 4 chance of those genes coming together, and then there's a genetic issue with the child. And in that situation, we have ways of avoiding it. We're not in a community where we say we're going to do genetic testing. If you're not compatible, you're not getting married. We're in a community that you find
Get married and you'll figure it out.
You find it and then you figure it out. And so what we do in those situations, we do IVF, we create embryos, and then we can test the embryos to make sure they're genetically healthy. So we're only putting a healthy embryo into your uterus. Now and our testing is about 98% accurate. So we can get pretty good. Nothing's ever 100% obviously in life, but if we're avoiding potentially something that's really serious, whether it's something that could be lethal to a child, it could be severe disabilities, deafness, blindness, etc. These sorts of things that we can avoid. There are times in the where I have couples that end up having a child unfortunately affected by something, and then they come to me for subsequent children. Or there are couples that are being proactive and they go to their OBGYN and they say, I want to have genetic testing, and they have genetic testing, they end up finding something, and then they come to me and we do this sorts of things, and we can create embryos, and we can create embryos for their entire family up front even. If you say, I want to have this many kids, we can do IVF. It may take a couple of rounds potentially, but we can bank enough embryos that you have for the future, so that when you're ready for the next, you just, you
let's
sort of
say you just want to, like, you just call and say, I'm ready. And
you go, I'm ready for my next one.
And then
we make sure uterus is okay.
Wow.
We take our frozen embryos that we have from the past that were created 10 years ago, 5 years ago, 20 years ago, and we can use them.
So very important is to test.
I think it's very important. I would
before
encourage.
You start having kids.
I would highly encourage
tested.
it. But I want to be mindful also of the fact that a lot of people don't feel comfortable with this sort of information.
Why?
Right? Because a lot of people feel that, it's just, it is what it is. And
wouldn't you want to know? It's not what it is. What it is. You just said you could take it out.
Well, we can avoid it, but not everybody feels this way. It's just what I see
anecdotally.
Just to put it out there.
A lot, and I think a lot of it is more traditional thinking within the community. Really more so from the older generations. Well, in my day, we didn't do any testing and everything's fine, and then whatever it is, obviously we have, in my mind, we have the tools, we have something we can do about it.
We have technology.
Some people don't want the information. They say, it's too much, it's too overwhelming. And of course, if it's too overwhelming for you, you don't want that additional information, you don't take it. You do whatever's right for you. But I think it's worthwhile at least having the conversation about doing it.
Agree.
Love that. And let's say someone is going through an IVF cycle or struggling with infertility. What are some ways you could support them?
So there are a lot of good resources out there. People who are going through struggles really need family, they need friends. I'm going to give a shout out to SPH. I think they're doing
SPH Fertility is changing lives. Go everybody who works there, and we're so lucky to have you in the community.
Yes,
we are very lucky. They launched 2019. When I was going through fertility struggles, this did not exist. There's services for women, for men, for couples, for the parents of couples that are going through struggles. The SBH has an incredible program that they have going on. Incredible support.
Yeah.
No matter who you are, or I just feel like at this point, like if you're going through a thing like such as infertility, we're so lucky. We should all take advantage of it. I feel like sometimes people are like, oh, I don't know. I don't want people to know my business. It's not for me.
Yeah.
How important are those resources for even the chances of what you're doing?
They are so important. They are so important. Infertility does not discriminate. It is prevalent. It is here. Should be seen as a medical condition, just like everything else. Nobody chooses to be infertile. Nobody, people aren't doing things to cause them to be infertile. When you have the same way you can have a kid who has asthma, their lungs aren't functioning the way that they should. Someone who has type 1 diabetes, their pancreas isn't working the way that it should, and they need insulin, they need medicine. It's the same thing with your reproductive organs. Sperm, eggs, uterus tubes, these things sometimes are just dysfunctional, and we need some help with it, and there's nothing to be ashamed of with that, and we have treatment for it. And I think it's something that should be spoken about and embraced. And again, I'm so happy we're having this conversation about this. This is fun.
We needed to have this. We need to put it out there.
We need to put it out there. I'm very happy you guys are doing this. I'm really appreciative that you guys invited me to come speak with you guys and just spread the word. And just, again, these are just conversations that are okay to be had, in this sort of form and with friends and family and things like that. It's just.
And if someone's listening to this on their walk and they feel connected to it, like, we're just happy to be there.
Yeah, or if they're thinking about it, is there any steps you recommend to take? Call your OB, make an appointment. Yeah,
I would say start with your OB. You start with your OBGYN. You can do even a basic evaluation, but talk to them about whether you have concerns, about building a family. And if they, and they can refer you to a specialist if they need. There are situations where you can go straight to one, of course, if there's a known issue. But start with your OBGYN and just have these conversations and be proactive.
Yeah. Okay, great.
Thank you.
Thank you for so much for being here.
Thank you for having me.
Thank you. Thanks for watching OffBrand with OnBrand. We had a great conversation.
Drop any comments, questions below, any other topics you guys want to hear about. Thanks for listening.
And shout out to SPH Fertility for doing everything that you do. You're the best.
We love you.